Hi, my name is John Bennett. I'm going to be a senior this year at Lake Ridge Academy, and today I'm going to be presenting on the prevalence of subclavian abnormalities in patients with atherosclerotic internal carotid artery disease detected by duplex carotid artery ultrasound. Background: the aorta and its branches. After the blood has been oxygenated in the lungs, it moves through the pulmonary veins and flows into the heart into the left atrium. From the left atrium, it flows into the left ventricle and then flows into the aorta. In the arch of the aorta, there are three different branches that distributes blood to the upper portion of the body. The left brachiocephalic artery, the left common carotid artery, and the left subclavian artery are the branches. The brachiocephalic artery then breaks off into the right subclavian artery and the right common carotid artery. Background: branches of the subclavian artery. The subclavian arteries are the major blood supplies to the arms. The subclavian arteries also supply blood flow to several other important arteries in the upper body. The internal mammary artery is important because it's used frequently during coronary artery bypass grafting. And also, the left subclavian artery also feeds the left vertebral artery, and same on the right side. The left vertebral artery is important because it supplies flow to the neck. Background: atherosclerosis. Atherosclerosis is an arterial disease in which blockage results from plaque in the blood vessels. When there becomes a lot of plaque in the blood vessels, it accumulates on the sides and causes narrowing or stenosis in the blood vessel. This causes turbulent flow and accelerated flow in the blood vessels. This results from many contributing risk factors, including tobacco use, high cholesterol, and hypertension. Background: stenosis detected by Doppler ultrasound. One method for detecting stenosis in the blood is by using Doppler ultrasound. The ultrasound can detect stenosis by measuring turbulent flow in the blood vessels and showing a narrowing in the artery. Another way that it can detect stenosis is by measuring the velocity, as you can see in the top left of the picture. Think of it as a garden hose. When you put your thumb over a garden hose, it causes accelerated flow, turbulent flow of the water, and the water sprays out of the hose faster. The same is true as in the blood vessel. The plaque acts as the thumb, and the blood sprays turbulently and faster. So they also use velocities to detect stenosis. Background: stenosis detected by angiography. Angiograms can detect stenosis when dye flows through the blood vessel. Catheters are inserted up into the blood vessel, into the subclavian artery, and it can measure and see the blood flow through the subclavian artery. From there, you can measure stenosis by showing the shortest or narrowest point in the blood vessel and then measuring the point distal to that narrowest point that's the most normal. Background: stroke. Stroke is one of the major causes of death in the United States, and it's one of the major causes of stroke is atherosclerosis of the carotid arteries. Carotid duplex ultrasonography, or CDU, is the most common imaging study used to detect blockages in the arteries leading to the brain. The purpose of this research is to determine a correlation between carotid artery atherosclerosis and subclavian artery atherosclerosis. During a CDU, the subclavian arteries are also imaged. We hypothesize that patients with evidence of carotid atherosclerosis on CDU will also very likely have atherosclerosis in their subclavian arteries, as atherosclerosis is a systemic disease. Our methodology: we queried the non-invasive vascular laboratory database for all patients who had a CDU from January of 2011 to May of 2011. From that database, we examined medical records and found how many of those patients had an angiography procedure within 30 days of their CDU. We then analyzed the angiography to determine whether or not the study had any pictures of the right or left subclavian artery. If the study did, it was included. However, if there were no subclavian images, or if the patient had a subclavian artery stent, graft, aneurysm, or an aortic balloon pump, the study was excluded. From the angiography of the subclavian artery, we were able to measure the degree of stenosis in the subclavian artery using a semi-automated border detection program. Data included patients. From January of 2011 to May of 2011, the Cleveland Clinic performed 3,707 CDUs. Of those, 138 had angiographies of the subclavian artery within 30 days of the CDU, which adds up to 3.3%. Of those 138, 121 met all of the inclusion criteria and were included for analysis, which is 87.7%. In total, 3.3% of patients reviewed were included for the study. Data, example of a normal subclavian artery. The angiography of the left subclavian artery in A does not suggest any stenosis but in B, as you can see by the border detection program, there is no stenosis. So the belief that there is no stenosis in this artery is verified. Data, example of an abnormal subclavian artery. As you can see in figure 2, an angiogram of the left subclavian artery in A, you can see that there is a clear narrowing right above the origin of the subclavian artery, and in B, the border detection program verifies our belief. However, in C and D, in the ultrasound of that same subclavian artery, there does not appear to be any abnormalities. In figures E and F, though, in the carotid arteries, you can clearly see that there is plaque present in the carotid arteries. Our results, and here's the statistical analysis of our included patients. Out of all of the 121 included patients, 75.2% of them were male, and their average age was about 69. The vast majority of them had this ultrasound because of preoperative clearance. In regards to the stenosis values, the internal carotid artery abnormalities on ultrasound, 111 patients that were included out of the 121 had abnormalities on the ultrasound of their subclavian artery. In regards to the ultrasounds of the right and left subclavian artery, 51 or 42.1% of those had abnormalities in their right subclavian, and 19.8% of those patients had left subclavian artery abnormalities on their ultrasounds. However, for the 117 patients included in the study that had angiography procedures of their left subclavian, 76.1% of them had abnormalities in their subclavian artery. For the 11 patients that had abnormalities in their right subclavian, for the 11 that had angiography procedures of their right subclavian artery, 81.8% of them had abnormalities in their right subclavian. And here's a comparison of detecting stenosis by angiography in the subclavian artery, and here's and ultrasound and angiography in their subclavian arteries. For all of the patients that had internal carotid artery abnormalities on their ultrasound, only 51.4% had subclavian artery abnormalities on their ultrasound. However, 77.7% had abnormalities on their angiography in their subclavian arteries. That's more than a 20% difference. Our conclusions. Atherosclerosis was a common finding in the arteries of patients who present for CDU. Over 90% of the patients who present for CDU have the presence of an atherosclerotic plaque or an atherosclerotic narrowing in their carotid arteries. There is a high correlation, 77.7%, of ICA atherosclerosis detected by ultrasonography and subclavian artery atherosclerosis detected by angiography. However, there is an inconsistency between atherosclerosis of the subclavian artery detected by angiography and atherosclerosis of the subclavian artery detected by ultrasound in patients. Angiography is a better detector for atherosclerosis in the subclavian artery. Our recommendations: atherosclerosis of the subclavian artery is common in patients with internal carotid artery atherosclerosis. Abnormalities of the subclavian arteries, including the presence of plaque in patients with internal carotid artery atherosclerosis, should be more noted and reported so that more stenosis can be reported. And finally, I would like to acknowledge all of the people that generously donated their time to help me with this research. Dr. Esther Kim, my primary mentor, Dr. Heather Gornick, my secondary mentor, Sue Whitelaw, Sandy Yasenko, Miriam Khan, Jessica Lowy, Adil Menon, Eva Ballas, Brian Caputer, my peer mentor, and Nedra Starling and the entire Office of Civic Education Initiatives. Thank you very much.